But while people are joining, Dr. D, I'd like you to know, actually, I'm going to pull up my data because it's actually been fascinating to see what proper pre-bolusing looks like in Tidepool. Oh my goodness. The thing that I hate, I mean, we're going to burying the lead, right? The thing that I hate is that it works. um, I think that's like a broader theme around like all of the settings stuff that we do or that we talk about is that the problem with all of the work that you put in is that more often than not you can see progress. You can see that you can see the changes taking place as you're reviewing data. It's not quite real time, but it's like if you it's not quite like if you put your mind to it, Saturday morning cartoon special sort of thing. But, you know, in my specific use case, the data shows that pre-bolusing works, at least for breakfast.
Yeah, yeah,
There's a separate matter for what happens between noon and 5 p.m.
sure.
And we're not gonna talk about that.
There are other things, but I think you bring up a really important point that reminds me to always say, when we look at the data, you're not just looking for problem spots. You also should be looking for bright spots where things do work, and you say, okay, like this is working. It's that positive reinforcement is really important. Should not never underestimate the value and the impact of positive reinforcement, even for yourself. As you own data, you're looking at the data yourself and you say, that works. So don't be fooled and sort of trapped into looking for the problem areas. There's lots of bright spots that one should be proud of as well.
Yeah. Hi, everybody. Dr. D and I are just going to have a casual conversation. As you have questions around settings related to your insulin pump adventures, chime in, use the Q&A button at the bottom, and I will ask them on your behalf. As a quick reminder, while I am currently uploading my data just to show you all how pre-bolusing has worked for me, don't forget you can go to tidepool.org/webinars, and you can see all of the past webinars we've done. There's a whole healthy display of on-demand videos, including from Dr. D talking about basal optimization, insulin-to-carb ratio, insulin sensitivity factor, all sorts of fun stuff there. Tidepool.org/webinars. We've got more webinars planned for the next couple of months. They'll all be shared on Tidepool.org/webinars. If you're watching this, you're likely on our mailing list, so I will be contacting you to promote future webinars, so stick around for all of those. But yeah, as you have questions about stuff, we're here to answer them for the next hour or so. Otherwise, I'm just going to keep sharing my data and we're going to have an informal session around all of that. All right, I've uploaded my data for the past 2 weeks. Let's refresh. And then this is going to be, all right, everybody. My data, don't judge. I'm a real person with diabetes here. All righty. So here's my data in Tidepool. Again, I'm using Control IQ. Everybody close your eyes real quick. We're going to go with the honor system here. I'm going to wait for the big reveal of what has happened. So it's probably been about 3-ish weeks of me really trying to pre-bolus. So I have a homemade granola recipe. It's really fantastic. If you really want to know what it is, shoot me a message and I will share the recipe with you. It's really, really good. The problem here though, actually, whenever the data actually loads, come on now, there we go. The problem is that I don't do a good job of pre-bolusing for my breakfast. So here's 2 weeks of data. Here's 4 weeks of CGM data. So you can see when I'm eating my breakfast, right? You see around 7 a.m. You see all these excursions here, this like super gap right here. I'm going to take this down. You can see where the data excursions are from my CGM readings around this 7 to 9 a.m. window here. This is mostly because I bolus and I eat right away. And that granola, those oats are really effective. And eventually my blood sugar will come back down. Control IQ does a little bit of auto bolusing. Things get back down into green, into my target range. And then Dr. D very kindly recommended multiple times, because I'm a stubborn patient. Excuse me, I'm not his patient. I'm a stubborn person with diabetes. But he had suggested that I consciously pre-bolus, wait 10 to 15 minutes, and then eat my food. And let's see what happens once I do that. Look at that bump from 7 to 10 a.m. Again, I'm the person with diabetes. Dr. D is not my doctor. He's just making a kind recommendation to me. And it's up to me to enact, to make that decision, to do that consciously. But I'm also not a doctor providing medical advice to any of you out there in diabetes land. But again, here is the data to show you what happens whenever you review your data with your medical professional, discuss opportunities for improvement, and go on from there. It's a fascinating thing. I don't know, like I'm an
I,
N of one, right? Like this is just me. It's just because I've been focused on that specific thing. Who knows how long I'm able to keep it up? But the data does show that using the data to help reinforce the conversations around optimizing your settings, improving your diabetes management approach, it's possible. Yay! What you didn't see,
exactly.
and I'm going to stop. I stopped sharing my screen. Is what happens around lunchtime. I'm
Yeah.
real bad at remembering to
Yeah,
bolus for
no, I
lunch.
think that's a great illustration, a great story that illustrates so many things, including the fact that sometimes it's not about the insulin adjustments; it's really about the behavior. The insulin to carb ratio works just fine, and all we have to do is just change the timing of something, or using a certain feature that we don't necessarily always use. That's number one. Number two is looking at the data, how important it is to recognize what the challenge may be. And also when we fix something, just one thing at a time, and then you can see how much of a difference that makes. If it didn't make any difference, then you say, okay, well, that wasn't it. I need to find something else. Or it didn't fix everything, it fixed it halfway, then we can say, it's not about the timing anymore. It may also be the insulin to carb ratio, or maybe the basal rate that needs to be adjusted. So we
Yeah.
can work on that one thing at a time. I think you've also illustrated how, if you know how to use Tidepool, you can actually sort of very quickly see the impact of the intervention that you've done. So play with it. No one's going to teach you exactly how to do it. I try, but play with it. The more you play with it, just like any other game, anything else on your computer or your smartphone, eventually you can learn how to use it.
Yeah. And I think that's a question that we saw quite regularly actually over the past couple of webinars that we've done, talking about different approaches to settings optimization, different aspects of it, basal rate, insulin carb ratio, things like that. Is how do you know where to draw the line between this is a settings thing or this is a behavior thing? And behavior sounds harsh, but there is a line between okay, like the numbers and the math is in a good place, and we just have to work on improving the habits, improving the routine that is fully in control of the person with diabetes. Like how do you go about engaging in those conversations whenever there are more knobs you can tweak on the pump settings side, but sometimes it is just like a face-to-face conversation or screen-to-screen conversation because global pandemic. But how do you know when and where to draw the line there and stop tweaking on the settings side and start talking more about habits and routine and things like that?
Yeah, I think that sometimes just comes honestly with experience, where I can look at the numbers and you say, look, we're already at 1 to 9 grams of carbohydrates ratio. There's no way that this 8-year-old can require more than 1 to 9 grams. So I trust that it's not the insulin to carb ratio, it's already too strong. And I think we need to look for something else. So that's just one example. And the other is just looking through the data and finding, sifting through the data and finding that one day where things did work and say, well, how come this one worked? And sort of just look for cues as to, was it the timing of the bolus? Was it the calculation of the carbs? Was it the fact that there was some exercise, or whatever it was? Sometimes looking for those times when things did work very well can give you a lot of clues as to what's working and what's not working.
Yeah. When it comes to having conversations with patients that are not fully responsible for their diabetes management, when you're talking with pediatric patients, or often talking with caregivers, how do you navigate that sort of tricky balance where it's not up to you to provide, it's not even your domain to provide parenting advice, but as part of their role as a caregiver, they're responsible for some aspect of diabetes management and those habits of the person with diabetes. Like things get more complex when you start, adding people to the equation. And when it comes to talking to a parent who's responsible for a child with diabetes, like that's going to get real messy. How do you begin to navigate those conversations as it relates to the data too?
Yeah, it's a good question. Things gotten complicated with, shared data through the phone, so everybody knows what the CGM data looks like, and who's bolusing and who's not bolusing. You can do things remotely, but my personal philosophy, and I'm not saying that this is the right, 100% right, but my personal philosophy has always been that it's the parent's responsibility to do the diabetes management. And I say that not to punish the parents, but actually to advocate for the child, because diabetes is really hard. And to put it in the hands of a child of any age, is unfair. I think we need to set certain expectations of the children and say, for example, if you're going to eat something, you have to tell me about it. It's okay, you can eat it, but I need to know. As opposed to if you're going to eat something, you have to bolus for it. That recommendation comes very individually. So it depends on the child, it depends on the age, it depends on are they capable of doing it or not, and it depends are they teenagers or not. If they're teenagers, forget it. You can't expect them to actually bolus every single time they eat. If it's a younger child, there is no way that I'm asking a 6-year-old or an 8-year-old that, hey, you need to bolus for everything you eat. For that child, it's actually more, I need you to tell me when you're going to eat something. It's okay, you can have it, but I need you to tell me every time you eat something. And they're going to forget because that's just life. So the key is let the child be a child. Don't take away part of their childhood, part of their spontaneity, and add more responsibility. It's a huge responsibility. Managing type 1 diabetes is not a small thing. I don't want a child to be feeling responsible for it. It's really the parent and the caregiver.
Got a couple of questions coming in from the attendees. Thank you, everybody. This one is from Michelle, and she might just be speaking my language right now. I tend to snack a lot at night after dinner. Are there general recommendations of how to handle this? That is just speaking right to my core.
Yeah.
Yes.
Yeah. So how to handle it, meaning like how to dose for it, is one thing, as opposed to what would
Stop snacking.
what would be my advice? Let me start with my big advice, which I think is it's an observation that I've seen over the decades, which is not necessarily only for people with diabetes, but also for people without diabetes. The healthiest thing, the ideal thing you can do is to absolutely eat nothing in the last 2 hours before going to bed. You will sleep so that you allow your stomach to digest and empty by the time you're falling asleep. And if that is the case, if you have diabetes, it makes it so much easier to control your blood sugar at night. And if you don't have diabetes, you actually sleep better. The quality of sleep will be better. And you wake up in the morning completely empty stomach, as opposed to some indigestion still left in there. And remember that even the process of multiple eating all the time, that's actually affecting the process of digestion as well. So it's better to take that whole amount and eat it at once and then stop. You digest it, you clear your stomach, it's empty, now you can go to sleep. It's really, really hard to control blood sugar at night, which is the opportunity to do so if you are still eating and snacking before bedtime. But if you're going to do it, I would say for children, my recommendation is always pick one healthy snack and have it consistently every night before dinner, like a glass of milk and a piece of cake or a piece of fruit. Whatever it is that you like, be consistent with the amount and be consistent with the type of food that you're eating. So you know exactly how much and how to dose for it, because you're going to do some testing for it if you eat the same thing every night. But ideally, 2 hours before bedtime, the kitchen is closed, that's it, we're done, and we're going to go to bed.
I'm just going to focus on the part where you said have a piece of cake before you go to sleep every night. It's like, all right.
Yeah, I'm not limiting. I don't want to limit what you have. If you want to have it, just have it consistently so you learn how to bolus for it.
Yeah. Something that you had touched on in a couple of these webinars was when it comes to reviewing data, either with your provider, with your child, or whoever, like when it comes to just the act of engaging with your data, You've talked a little bit about sort of like minimum requirements, like how much data do you consider to be worthy of a trend to enact either a discussion or some sort of settings change? Can you go back over that again? Like how much data is just enough? How much data do you consider to be ideal to go about adjusting basal settings or anything like that?
Yeah, so there are two questions embedded in your question. One is, it would be nice to have at least 7 days of data. And at most 14 to 21 days, but you don't necessarily have to go beyond 14. I think 14 days have been shown actually in studies to be enough to represent what normally happens overall in broad terms. Looking beyond the past 2 to 3 weeks, then especially in children, then it's all data because they're just changing constantly. So I would not actually make a recommendation based on data that somebody's given me from a month ago and say, well, that was a month ago. Who knows what happened and who knows what happened between now and then. Growth spurts, illnesses, sports, etc., the climate, the seasons change. So I would look in the past 1 to 2 weeks and make the recommendation. How how long is a trend? I would say, again, never make a change based on one event that happened one time. You want to see the same thing happening consistently 3 or 4 times, not necessarily in a row, but let's say 3 or 4 times in a single week. So 3 and 4 days out of 7, the same thing is happening, then that's a trend. Then I think that confirms it, and then you should go ahead and make the change. And then wait another week. So you make a change. Don't go back and look the next morning and say, oh, that didn't work, I need more. No, give it some time. Take a break, make the change, wait another week and come back and see.
Right on. Question in from Steve. Thank you, Steve. In an earlier webinar, Dr. Adi, you mentioned prepubertal and postpubertal basal patterns. What was the wake and bedtime times for those patterns, especially the wake time for postpubertal? You may have to slip the dawn rise as I wake at 9 a.m. It's from Steve from the UK. Thanks for staying up for us. Actually, it's not that late, but anyway. Yeah, I remember this was from that basal optimization slide deck where you had a couple of like general graphs that were showing some things to at least begin to review.
I'm going to see if I can find it.
There we go.
There.
That's the winner.
That's the winner. So that really worked very well. You can see it. So here's the prepubertal pattern here in the upper half, where we're starting with the midnight and then going to 3 a.m., 6 a.m., noon, and then back to midnight again. And here's the pattern. The pattern is, remember 2 things, that right after going to bed, going to sleep at 7:30, that's the highest basal requirement of a prepubertal child. This is going to be the peak. They require a lot of insulin right here between 8 and midnight. Depends on what time you go to sleep, etc. But if you go to sleep at 10, then you shift that whole pattern 2 or 3 hours to the right. But let's say a child who goes to bed at 7:30 or 8 o'clock, this is where it's going to be the peak of insulin requirement. And quickly after that, right after midnight, it drops to the lowest basal insulin requirement right here. You can see that on the left. So here's midnight, being the highest right before midnight, dropping quickly to the lowest right after midnight between 1 and 3 a.m. And then gradually increasing back up to that morning rise. But that morning rise in prepubertal children is always going to be less than the first part of the night. This is always going to be higher than this one. And then it drops somewhere in between, having that basal rate during the day, and it should be pretty consistent unless there's some adjustments for activities and exercise and lunchtime. But otherwise, this is the pattern that you will see. And I put these numbers in green just to illustrate sort of the magnitude of the change. It can easily be 0.25, for example, for let's say a 4 or 5 year old. And just 3 hours before that, it was actually double that. It was 0.5 and sometimes even 0.55, just to illustrate how quickly this drops. And that's why you kind of have to go into those basal rates here every hour and just gradually decrease them, making step by step to drop from that highest basal to the lowest basal. I hope that answers your question, Dave.
That does. And you see a similar sort of not as similar, but you see the adjustments that I guess the body is making post puberty below, as
So,
you're seeing sort of
right, right.
scale
So
the
that, yeah.
relative there.
So the post-puberty here is that now the hormones that are causing this, the hormones that are causing this high insulin requirements right here are causing insulin resistance. And that's why you need more insulin right here. And the hormones that cause that insulin resistance now are actually aggregating here in the morning because now we're making testosterone and cortisol in the morning. And that's what causes the higher insulin requirement here, the dawn phenomenon. And that growth hormone surge that happens at night is no longer there. That's why you don't need that high basal here anymore. Now you need the highest basal being up here. So you go from highest basal being down here and shifting that all the way to the morning. And that process is gradually just shifting that blue line that you see, flattening the evening time and raising the peak in the morning. That process is a process of several months happening. This isn't something that happens just overnight or over a week. From the time puberty happens, I would say you shift that pattern from the prepubertal to postpubertal in a span of 2 to 3 years before you get there.
Right on. Thank you for that one. Thank you, Steve, for your question. Yeah, I got another question in from Amanda. Thank you, Amanda. Another snacking question. I think we've touched the topic here. My newly diagnosed 4-year-old wants to snack all day. I guess that makes me also a 4-year-old. I can sympathize there. It's hard to have 3 hours between eating snacks and meals to be able to correct her BG. How do we properly correct her BG, but also allow her to eat? So we touched on this already about, letting the kid be a kid, but also they've got diabetes. So how do you recommend being able to navigate that?
Yeah. So this is a completely different area, and we have to sort of address it differently.
Okay.
A 4-year-old, number one, and then recently diagnosed is a completely different factor. So a 4-year-old naturally is going to snack. So, they're supposed to be snacking every 3 to 4 hours. So we can't say, no, you're going to eat 3 meals a day and that's it. They're going to snack. Now, snacking every 10 minutes, that's a whole different story. I'd say, well, let's start slowly but gradually setting the limitations. But having said that, I would not actually start doing that right now because I think Amanda mentioned the newly diagnosed child.
Yes.
So with new diagnosis, the body is trying to make up for all the losses that have happened over the previous 2 or 3 months before diagnosis. The body had been starving, and all of a sudden you're providing insulin, and the body is now saying, oh my God, now I'm actually seeing all that food coming into the cells, and particularly into the cells of the brain. So the brain centers that are responsible for controlling satiety and hunger and metabolism are also looking there and saying, now there's food. And I don't know what happened 3 months ago, but now this is an opportunity. I don't know how long this is going to last. So I'm just going to be hungry all the time. And I want to take that opportunity and rebuild my body. And that's exactly why newly diagnosed children and even adults, when they first start taking insulin for the first 2 to 4 weeks, they are constantly eating all day because the body is just hungry for it. They want to build what they lost before. So allow that to happen. That's normal. Don't worry about it and just let it be. It will only take about a couple of months. And after that, it starts slowing down. Now, the problem is that it may become a habit. So you, as a parent, you do want to put limits. And the limits would be just like what you would do with a child without diabetes. If you have multiple children, then the rules should be the same for everyone. If you tell your child with type 1 diabetes, no, you can't eat now, you have to wait an hour, then everybody else can't eat now, you have to wait an hour. And those limitations or structures, I should say, I would hate to make a limitation, it's more geared towards a healthier lifestyle, a healthier routine that applies to everyone. But super importantly, to apply for children with diabetes because it's really hard to bolus for every 3 or 4 grams every 10 minutes. It's just, this is where automated insulin delivery can help a lot by having a closed loop system. But even then, if you're just constantly eating, it's hard to do that. But I would say for, I think this, maybe it was hidden in there, the specific question as to Well, when do you actually give a bolus for a correction? If you're just eating every 30 minutes, it's hard to have that 3 hours in between and you say, okay, now I have to give a correction. And the answer is that I think if you have an insulin pump, and you should, then the bolus calculator is already factoring in how much insulin is still on board and when you should add an extra correction or not. But you should be bolusing for every little snack, every 2 or 3 grams that he or she eats, every time just bolus for it and let the bolus calculator tell you when you need a correction.
That's actually an interesting thing. And I want to be careful how we talk about this because we're not like an infomercial for, Insulet or Tandem or anything. But when I was first diagnosed, I was put on insulin pens, and every bolus was like a really specific conscious decision because that was an insulin pen needle. Like you're going to screw this thing on and use it. And so it's a one and done sort of thing. And that mentality, switching over to pump therapy, it took me a while to be okay with like the random bolus for, not nothing, but for just like a random correction. Like I rarely just like switching over to how to take advantage of the features of an insulin pump, as you're working on adjusting those settings. Like that was a weird thing for me to try and wrap my head around at the time.
Mhm.
And I switched over to insulin pump as an adult. So like I was in theory, responsible for my own care, or at least responsible in theory. But when it comes to that sort of engagement with the technology, knowing that you're going to be having, there are plenty of patients out there that are going to start on, MDI and then come over to an insulin pump. How do you go about sort of, not just, it's something more complex than I think educating on pump therapy, but getting them to understand that there are these settings, that there's this extra like layer of machine and technology there that is there to help them and aid them in their process of diabetes management. Because it's more than just like, here's how you bolus, but it's here's how the settings are working to keep
Right,
you in range.
right,
It's
right.
like just that mentality of accepting and knowing that this technology is here to aid you and not be a burden. It's a really complex thing to try and navigate that goes beyond regular pump training, right?
Yeah. No, I think you're right. And it starts with an initial conversation before even starting on a pump, before ordering a pump. We sort of hide that into the class as to which pump should I use. But we spend half the time actually talking about pumps in general and how different dynamics they have, as opposed to taking multiple daily injections. When you're taking an injections, you're really doing the calculations, and you take that long-acting insulin, you're kind of stuck with it, and then you have to deal with it if it's too much or too little. And you can't really make small, tiny adjustments. The fact that you're no longer taking long-acting insulin, it's all short-acting insulin, changes the entire dynamic of how we think about insulin dosing, and how we think about insulin adjustments independently each day. And then the other thing is, when you stop taking long-acting insulin, it doesn't necessarily immediately clear out of your body, and all of a sudden the next day you start on a pump and everything should work like a pump use. There is a period of adjustment that the body have to take in order to switch completely from injections to insulin pump use, and that can be several days. So my recommendation is always, when you start on a pump, first you need to know the features. Second is trust it. If you're really not trusting it, then it's not very effective. And it actually makes you frustrated because you either overdo it or you underdo it. And you become more occupied because of all the things that you can tweak. Just take it easy. Trust this thing, give it time. Don't make too many changes at once or in a week or two. Let these things actually take time to sort of adjust. But I think that understanding the dynamics of bolus calculator and how it works in terms of what's the insulin on board and how much and how it counts those carbohydrates, and if it's long and if it's a long bolus, an extended bolus versus a regular bolus, those things come with time. And I think that it works better when we're actually reviewing the data. When you already have your pump, you have your CGM, and reviewing the data, and then showing in real life your own experience when you do an extended bolus, for example, how it works or how it doesn't work, and how you need to change those parameters.
Yeah, I've just been thinking about uh, the sort of, this is not quite Tidepool, but more therapy of like, okay, like there are these settings that I can adjust and work on. And, you know, the webinars are great, a tool for providers to use as a foundation for a discussion with their patients, along with other resources out there. But ultimately, like, I don't like to engage with my data just because it feels exhausting, even though I know that when I do, I can improve things, which would like, there's a pile on effect of, you know, likely positive, outcomes whenever I do engage with my data, but I also hate engaging with my data. And I work at Tidepool, which is a really weird thing. But broadly speaking, like, how do you, I guess, as a clinician working with patients that, you know, you have to manage that the mental gymnastics of diabetes management. When it comes to engaging with those settings adjustments, engaging with like, okay, for the next 2 weeks, we're going to pre-bolus 15 minutes and you need to document it and like work really hard on this. Like, how do you go about the mental side of that approach to the settings adjustment, task that is going to be handed down to the caregiver or the person with diabetes? Like,
Yeah.
there's a hurdle there, and we've talked about this many times, you and I, on these webinars. You know, personally, I've talked with my own endo about this. Like, I often struggle with knowing that there are things I need to do, knowing that I will be successful in them when and if I do them, but I don't want to actually start on that. And that's a
Yeah.
therapy thing, I realize,
Yeah.
as I'm
Well,
just verbally exposing my soul to everybody out there.
it's yes and no. And thanks for sharing your soul and your philosophies and psychology. And I do think that the encouraging engagement with the data is not an order. You can't just tell somebody, hey, you need to review your data. I think actually it starts in the clinic, in the office, or via a telehealth visit, which starts with the provider actually reviewing the data with the patient. You say, look at the insights that I don't expect you to do it because I do this for a living. I don't expect you to know this, but this is what I'm doing. This is how valuable the data is, and this is what we can get out of it when we look at it. So it's kind of just like a subliminal message that this is what I do, and I do it with them, and I verbalize what I'm doing, what I'm thinking, so that it becomes less daunting. And then we focus on one thing again, to keep it real simple. Here's what happens. This is when you ate. This is when you bolused, and this is when you did your exercise, and these are the results. Just pure. That's it. Even though there are opportunities to talk about extended boluses, to talk about pre-bolusing for breakfast, etc. Just like pick that one thing that's really simple, that's very obvious, and it makes sense. And I think honestly, this is not to advertise for Tidepool, but I think when you're
We can advertise for
looking
Tidepool. It is a Tidepool webinar. That's okay.
when that's all right. But when you're looking at the data, when you're looking at the CGM graph, it's no longer a hypothetical thing that if you had bolus before breakfast, I would have expected your blood sugar to be lower 2 hours later. It's just like, I don't have to explain that or paint that picture in somebody's head. It's right there on the screen in front of them, that visual impact. And you say, it did make a difference. It's much easier to explain it that way. And like I said, not everyone is going to be engaging with the data. Not everyone is going to like it. But if you keep it to a minimal, so it's not a burden, it's kind of make it a fun thing to do occasionally. We all do things that we don't like to do. Just minimize that uh, that event to maybe even once every 2 weeks, once a month, if that's the case. It's fun.
Yeah. For the record, I upload my data regularly. I've got 4 years of my data in Tidepool. I just don't look at it that often.
Yeah.
All right. Questions in from the participants. Thank you, everybody. Here's another one from Steve from the UK. There you go. This one is about insulin action duration. Does this differ much in adults from the pharmaceutical 4 hours? Do you evaluate what this figure is for each patient? Some of this is becoming a little more, not a little more complicated, but a little more complex because you can't necessarily set insulin duration in some pumps depending on the technology that they're using, right?
It depends on the system they're using. So, for example, people who use loop, they cannot set their or closed loops, I should say, they cannot set their insulin duration time. But if you're using a sensor augmented pump without a closed loop system, you can. So all the pumps you can adjust your insulin duration time. But to answer the question more generally. Is the insulin duration time or insulin action duration different from person to person? And is it different than what the insulin manufacturers tell you? The answer is absolutely yes. So generally speaking, 3 to 4 hours is about the average for the insulin dose that's given under the skin to complete its action and be cleared completely. Not completely like 100%. There will always be a tail left for the next, 6 hours or so. But that tail becomes minuscule, so it's no longer affecting your blood sugar significantly. So practically speaking, I would say the insulin action duration is about 3 to 4 hours in most people. But having said that, in children is very different. And it's highly dependent on the size of the child as well as the size of the dose. So the reason it takes 3 hours for an insulin dose to complete its action is that we're putting that insulin under the skin. And it's going to sit there and wait until it dissolves into single insulin molecule as opposed to a double insulin molecule for aspart and Humalog and Apidra. Those are made such that insulin molecules don't congregate too much so that they're easier to release and get absorbed from under the skin. But that process is still relatively slow compared to the insulin that we make in our body, because the insulin that we make in the beta cells goes out into the blood, goes through the liver, and reaches the rest of the body within 1 to 2 minutes, and it does its action and it's complete, it's done, compared to 3 to 4 hours. So the duration of insulin action, the injected insulin action, is not related to how long does it really take to actually do its action. It's directly related to how long does it take to get absorbed from the subcutaneous space into the bloodstream. It's how long does it take to reach the bloodstream. Once it's in the bloodstream, it has about 1 to 2 minutes to finish its action. So the smaller the dose, the quicker the absorption from under the skin is going to be. And the bigger the dose, there's going to be big glob of insulin molecules that are going to sit there. It's harder for it to actually dissociate and get absorbed into the bloodstream. That's why the smaller the dose, the shorter the duration. And an example of that would be half a unit of Humalog or Novolog. It does not last 3 or 4 hours. That's barely 2 to 2.5 hours. And you can see that by doing a correction, for example, by doing a dose and looking at your CGM data and seeing how long did it take for it to dropping the blood sugar and then eventually stop dropping. The CGM flatlined after that. So you look at that multiple times and you can take the average and you say, it looks like it's only lasting about 2 to 3 hours as opposed to 3 to 4 or even 4 to 6 hours. If somebody's taking 25 units of Humalog, I would expect that to last 3, 4, 5 hours or 6 hours even. But if you're taking half a unit in a child, that's barely going to last 2.5 hours.
So I'm mad at the part where you said that your properly functioning pancreas is just like instantaneous.
Exactly. And that's the key, is that the reason you can maintain such tight blood sugar normally is the fact that the response is instantaneous and the response is very quick. So you do its thing and then you stop and then you adjust. Or did I give too much? Did I do too little? And you keep adjusting so you can control that. And the other thing is, in order to control something very steady, you need to control it in both directions, up and down. So you have insulin and you have glucagon. If it goes too far down, you get the glucagon to kick it back up. If it goes way up, you get the insulin to bring it down. Unfortunately, with type 1 diabetes, we're controlling only one of those two directions, but not the other one. And it's lagging. So one direction control, and it's lagging, 30 minutes to 3 hours behind. That's why it's hard to keep it very tight.
This is the type of webinar we can give a shout out to our friends over at Beta Bionics who are working on the dual hormone pump therapy with their iLet insulin pump. Question from Anonymous. Thank you, Anonymous. Do you see any diabetic complications or diet making control more? Excuse me. Let me try this again. Do you see diabetic complications and diet making control more difficult? For example, my chronic kidney disease has severely reduced my insulin needs. Also recently changed to a whole food plant-based diet, which takes food longer to digest. Just throwing more variables at you in terms of how all this is going to work. But I think in particular, the plant-based diet thing is something that, I mean, I definitely see a lot of people with diabetes talking about, you know, for one reason or another, certain dietary restrictions that they have, either they have or they have placed upon themselves, and how that could impact how they go about, you know, the insulin side of things.
Yeah. Uh, and, and and I think we're still talking about type 1 diabetes, not type 2 diabetes. But generally speaking, you know, I'm fortunate not to have seen a lot of patients with complications because, again, I deal with pediatric patients mostly. And I have to say, I've actually never taken care of a patient with kidney problems because of diabetes. But if they have kidney issues because of other things, not as a complication of diabetes, I think definitely the function of the kidney impacts the clearance of the insulin. So it certainly has an effect on how much insulin do you need. But there are many other factors as to the general illness. What disease do you have? What type of inflammation do you have? How is it affecting your diet? So people with chronic kidney conditions may be on low protein diet, so they're eating more. They eat less meat and less fat, so that they're more plant-based diet, or that they choose to be on a plant-based diet with slower digestion and larger volume, because in order to get enough protein and nutrition you want to eat, you need to eat a little bit more, vegetables. So how that impacts, everything is related to the absorption of the food, the absorption of those carbohydrates that you're eating, the timing of the absorption, and how long does it take to digest. So yes, absolutely, there's an effect, and there will be adjustments needed. Those adjustments will be tailored based on what you're eating and how your GI system is working. And again, looking at the data and having a CGM is really the only way to sort of make those individualized adjustments and make sure that you're bolusing correctly. If you eat a large meal of beans and vegetables and greens, the absorption may be much slower than you think, and perhaps an extended bolus is really the right thing, but instead of giving a big bolus right away.
Thank you for that. Question in from Barbara. Thank you, Barbara. I'm using a pump. If I bolus for a meal, knowing that I will be reasonably active afterwards, I often reduce the bolus so I won't have too much insulin on board later. But then I go high straight after eating. Suggestions? I tend to find temp basals result in highs afterwards. Before you answer this, Dr. D, I'm going to promote the webinar that we did last time. This one right here, utilizing diabetes data to understand and evaluate the effect of everyday activities with Tidepool, because I'm pretty sure you talked about the impact of exercise in a couple of the examples there. So I'm going to let you talk for a few minutes here, but Barbara, I'm going to recommend you go back to this webinar because there was a lot more, regardless of how long Dr. Adi talks in these next few minutes. There's a whole full hour of him talking about this stuff in this webinar, and it was fantastic. That is that. Dr. Adi, if you'd like to summarize your broad thoughts on all of that, here you go.
Yeah. No, thank you for that. And we did cover that, but I'm happy to talk about it again. And I think as you were reading the question, it immediately sort of dawned on me. I think this is a classic example of exercise after a meal, where the effect of the exercise is really largely on the process of digestion and absorption of the food. If you eat your meal and you take your insulin, and then you go out and exercise, any of us, diabetes or not, if we eat a meal and go out and exercise, basically what the body is saying, my muscles are working hard. I need to shift all of the blood supply, the oxygen and the nutrition to the muscles. And the GI system, the stomach and the intestines, are not important right now. I don't need to give you any oxygen right now. What's important is for those muscles that are working and running hard. So all of a sudden, the digestion process completely stops if you go out and exercise right after you eat. So yes, it's like not eating at all. It's just like delay. You might as well eat an hour later after you finish your exercise. Sit down and relax. Now all of a sudden the body says, okay, the muscles are done working. Now let's get back to the stomach and give it some oxygen and blood so that it can finish that meal digestion. So basically, it's like not eating, but taking a bolus. And then that bolus is actually going to work even better and faster because you're exercising, because now you're more sensitive to the insulin because of the exercise. And also you're speeding up the absorption because you're exercising as well. And that, then you have this insulin working with no carbohydrates going in, have a low blood sugar. And then when you're completely done with all of that, you have a low blood sugar, you treat it, you go a little higher, and then 2 or 3 hours, 4 hours later, the food gets absorbed and digested, and then the blood sugar starts rising. So it's a classic example of dropping after the meal because you're exercising, and then 2 or 3 hours later going up and having hypoglycemia. So what do we do about that? One is, if you can exercise before you eat, not after, that would be much better. And it's healthier in general to do that. Diabetes or not, it's better to exercise first. Get your exercise to be more effective because you're doing it on an empty stomach with lower blood sugar and lower insulin level. Even if you don't have diabetes, you're lowering your insulin, so that the effect of the exercise, the benefit of the exercise is actually better if you're doing it on a fasting state. And then you come in and you're really hungry and you can go ahead and eat your meal, and then you bolus for it like you would. If that doesn't work, let's say, for example, children at school who get a lunch and then go out for recess, or have a lunch and then go out for a PE class after that. They're not going to change the system and the schedule of the school. So what do? We do kind of what you already are doing, which is to take less insulin, or maybe even not at all, and wait until you finish the exercise and come back, because now you know your stomach is going to work and digest the food. Now you can take the bolus for the food. It's kind of scary to do that and say, I ate 2 hours ago and now I'm not eating anything, but I'm taking 11 units now for food that I ate an hour ago. The answer is yes. You just have to sort of try it slowly, little bit by bit, so that you can trust that this is really actually working. It's not risky. Then you can go ahead and do it. And the other is, if you're using a pump without an automated insulin delivery, without closed loop, then you can also do an extended bolus. So you don't have to think about it. You can say, I'm going to exercise after lunch. I'm just going to do an extended bolus, because you cannot do a delayed bolus, but you can do an extended bolus. So you don't have to think about it.
So I know what you're thinking, Barbara. Hey, wouldn't it be great if I could actually see that actually taking place in Tidepool? Well, sure. Let's take a look at my data real quick. I'm just going to throw this one out there. This is me documenting a dog walk where we do have a couple of hills. It's a mile long, 21 minutes. I'm using Tidepool Mobile on my Android phone to document the dog walks for my review later on, because I don't remember precisely when I took the dog walk, but I eventually document this for my own review. Here you can see my CGM data here. Lots of dark purple because I'm above 250, regular purple right here between 250 and 180, and then green is in range. There's a pretty steep drop right here. Again, not a medical professional, but I'm just going to read you what I see. But I also know that I bolused for dinner right here. 30 grams entered in my pump. Here's my bolus of 4.7 units, but this was at 7:14 p.m. Eastern time. This dog walk was at 7:51. So between that time of the bolus and the dog walk, or because of the dog, you can see that dramatic drop because, as Dr. Adi was describing, insulin was doing its thing and my body was not necessarily digesting its food because I was being physically active for that walk, for that mile and change walk. And then after the walk, you can see the steady rise as my food is being absorbed again. So here's just one example of many I'm sure I could find in my own data, or anybody else could probably find in theirs as they're documenting stuff in Tidepool. The key with all this that I want to highlight here for patients, providers, anybody watching this, is that I can actually tell this story in part because I put a note in here and I'm able to remember this as I'm talking with my doctor, with all of you lovely people watching this webinar. Documenting this with Tidepool Mobile, putting these notes in, adds more context to your data and can paint a clearer picture, tell a more complete story around what's taking place. So whenever it does become time to review your data, when it does become time to take action upon the things you're able to see and identify, adding more information to your data can help. I think can only help. I don't want to speak with any certainty there, but adding that context definitely helps when it comes to reviewing that stuff. Using Tidepool to do that. That's why we're here for you. Cool. Question. Barbara's back in for a quick clarification. I was meaning that if I'm going to say do some gardening 1 to 2 hours after eating, then I have already gone high from the food. We might need to do a face-to-face on this one. But if you're bolusing, I was meaning that if I'm going to say do some gardening 1 to 2 hours after eating, then I've already gone high from the food.
Yeah.
So the challenge is it? Do you think is it relying on physical activity to then bring your blood glucose back down after the fact?
Yeah, I'm not sure. I'm not sure what Barbara means, but if that is the case, the answer is no. I think that if the exercise is going to lower the blood sugar, or the gardening is going to result in lowering the blood sugar, then I would perhaps take a little bit less insulin for the meal, or lower the basal rate. I think the ideal thing here is, you know that you're planning gardening in 2 hours from now. And if you're using a pump, and I understand Barbara is using a pump, that if you are planning on doing some sort of exercise, then an hour to an hour and a half before going out to the garden, lower your basal rate, do a temp basal down 50% to start with, and see if that works. Because you don't want to have a situation where you know your blood sugar is going to drop, and then you're going to feed it by taking some extra carbohydrates to prevent it from dropping, or that you're taking less insulin for the bolus to go up too high, because you're going to go up above 200 or maybe even above 250 before you start gardening, to make sure that you end up at 100 at the end of the gardening exercise. I think the ideal thing is, you're going to eat lunch. Okay, fine, eat your lunch, bolus for it like you normally do. Take a correction bolus if you need it. And then 30 minutes later, start lowering your basal rate. Do a temp basal for the next 3 hours at 50%. Then you're really getting your body ready to start the gardening exercise. And because you're taking half the amount of basal, you're probably not going to drop that much.
Yeah, I think the thing to keep in mind with all of these suggestions, and as you approach dealing, or as you approach these different physical activities and different sort of scenarios in your diabetes life, if you are using Tidepool to manage your data, I highly recommend taking advantage of the notes feature to document what you did, what you tried, and then you can actually use it to as a reference point to review what the results were, and use that as information to make any adjustments to how you might want to approach things in terms of the timing of a temp basal, or the amount of food that you ate, or anything like that. Documenting the inputs so you can actually see the result of the outputs, regardless of the scenario, regardless of the situation. The more information you have, the more informed you're going to be as you're looking to make any sort of changes. As you're consulting with your doctor, as a doctor consulting with your patient, as a doctor, you're going to rely on that information to come in to help provide a recommendation to your patient out there, right? So
exactly.
Yeah, so the notes feature is going to be a really big key there. Thank you, Barbara. I see you chiming in one last time. One more question, and then we can call it, from Anonymous. What about exercise with closed-loop systems? If you eat without a bolus, insulin will increase basal on its own. I'm going to give a quick shout out to Control IQ's exercise activity mode, because it's working on that sort of stuff. But broadly speaking, how does awareness of what the system is doing, and understanding of the algorithm as best as you can as a patient, as a doctor prescribing this to your patient, how do you go about engaging in those discussions when it comes to physical activity, knowing that the system is going to be doing things on its own within reason of the settings that you're putting into the thing?
Yeah. These are great questions that are coming up more and more, and we're actually I've designed a session about automated insulin delivery in the next big conference of the Pediatric Endocrine Society. And one of the topics that I wanted someone to address is, and invited a speaker to do that, is how we change our mindset around what we do with automated insulin delivery, and the changing role of the diabetes provider, because we do really need to understand how the algorithm is thinking and what is it doing, in order to tweak those parameters, tweak those knobs, and say, okay, that's working for me and that's not working for me. Because no matter how smart that automated insulin delivery system is, it's not going to work for everybody the same way. It all depends on your exercise. It depends on how quickly you drop. Remember, Christopher, we had to look at your data to determine that walk with the dog drops your blood sugar between 100 and 150 points. Now, when I first mentioned that, you're just like, there's no way I'm dropping 150 points with just a walk with a dog for 1 mile. And then we show the data, actually, no, it's real. You're dropping 150 points. And that's how we figured out how high you need to be ahead of time, and how much to lower your insulin, and see how to adjust those knobs in your exercise mode. But I think it's about a trial and learning. Look, this is what I did for this exercise. That didn't work, or was too much or too little. And then we tweak something and we go back and look at it again and see what worked or what not. But it starts with understanding what the system is really doing. And that's where things are getting a little bit more complicated. And just, again, little by little.
Yeah. All right. Amanda has come in with a final question, which I think is actually a great way to cap this one out. Thank you, everybody, for attending, for asking questions, for engaging with us in this lovely, lovely discussion. Thank you again, Amanda. Do you have a previous webinar recommendation discussing the start of using an insulin pump and how to understand the data of the pump and CGM together on Tidepool? For an insulin pump start, no. For reviewing data in Tidepool, I've got plenty of those. So you can go to tidepool.org/webinars. I've actually got a couple that go through my own data. There's a 3-part basic series of just getting started with Tidepool, from uploading and reviewing data and going from there. So that's that. I think moving forward, though, because we will be doing more webinars, I'm going to take this suggestion back to the rest of the Tidepool team, and I'm going to see what we can cook up for you, and we can go from there. So how does that sound? I'm just going to assume you give me a thumbs up on that one.
And for after starting on the pump, then how do you adjust your, we have those webinars about optimizing the basal rate and optimizing the insulin to carb ratio and ISF. I think you will find those helpful as well. And they're on the website too.
Definitely. Steve has offered a very lovely thank you. Thank you, Steve, from the UK. All right, we're going to call it there. Thank you, Dr. D, for, I don't know, sitting around for an hour and shooting the breeze with me. This is always fun.
I love doing that.
Yeah. Thank you again, everybody out there, for attending this webinar. Again, tidepool.org/webinars is the place to go for this archive, past archives of all the other webinars we've done, as well as links to sign up for future webinars we've got upcoming in the next few months. That's all I've got. And when in doubt, if you ever have any questions, support@tidepool.org. I may answer, Nick may answer, Abby may answer. We just hired a new person, Kyle. He's great. Dave is also there. The whole support team is just ready to help. Support@tidepool.org. That's it for me. Christopher Snider, your Community and Clinic Success Manager at Tidepool. Dr. Saleh Adi, thank you again from the West Coast. Y'all have a great day.
Thank you very much. Appreciate it.